Yeah, hello, am I audible? Hello,
Yeah, sir.
I'm calling from second OT. I'm Dr. Sudish from Patna. I'm going to start RIRS, retrograde intrarenal surgery, and I will use the laser. This patient, Tarun Kavi, 30 years male, he was having 10 stone in the right PU junction. Am I audible? Yeah, so this patient having 10 stone in the right PUJ with hydronephrosis, and DJ stent was placed. This plate is after placing the DJ stent. You can see the stone, small stone around 10 No, it's a little bit near lower part, means yeah, it's I think 3-4 centimeter lower than UP junction. But it was written in this report PUJ. You can see this. Can you see this IVP? We can say this is stone in the upper ureter. Yeah, so in this, just focus this plate. This IVP plate, here we can see this stone and this dilated pelvis. This is up to here. Now I want to demonstrate the equipments. So I'm planning to use flexible ureteroscope for this stone, because this stone will go easily into the renal pelvis.
So when was the DJ put in this patient?
2 weeks, yeah, 2 weeks ago. There is no particular guidelines, but we usually keep minimum 1 week to 3 weeks, and that will give enough dilatation to put my access sheath.
Any drugs also you had?
Yeah, during stenting we keep on antibiotics like levoflox or nitrofurantoin for 1 to 2 weeks, and tamsulosin, sometimes anticholinergic like mirabegron. So what are the things required for this RIRS? Just I will introduce first the equipments and then I will demonstrate the procedure. This patient has on stent, so first I will do the cystoscopy through ureteroscope. So I will start with this semi-rigid ureteroscope. This is 6 French scope. I will go inside, I will see the bladder and ureteric opening, the stent. I will remove the stent and I will do ureteroscopy first. After ureteroscopy I will put the guide wire, and then on guide wire I will put the access sheath. I will remove the obturator. Then I will put the flexible ureteroscope. That is the procedure. So here it's
you start with the semi-rigid, I suppose.
Yes, of course. Just to see the condition of ureter, is dilated or not dilated, is there any stone or anything, so that is very important. Before putting access sheath, I will do the ureteroscopy up to the UP junction.
The audience will like to know what's the size of the ureteroscope you are using.
I got this 6.5 ureteroscope. There is no clear-cut guideline for this. You can use 7 or anything which can pass up to the UP junction. So this I got 6 or 6.5. This is 9.5 and 11. Means this is 9.5 and the outer sheath is 11. We need some guide wire. Here I have got this thermo, but I am using in my place sensor. The tip will be floppy and the other part will be hard little bit, so that it will be easy to pass the access sheath and flexible ureteroscope.
The guide wire is 0.35 or 0.38 or 0.25?
It's a 3.5, but routinely we are using 3.5. Sometimes we use this pathfinder, or otherwise I use this. This is PM line. This usually we use in syringe pump. So I will put this on the flexible ureteroscope, and one stop will push the water through this syringe. And if there will be rise of intrarenal pressure, we can withdraw through this. So this has got a double benefit.
Beginner to start RIRS.
First he will have to be master in cystoscopy and ureteroscopy.
Yeah.
Then only he can do the flexible ureteroscopy. And the monitoring is very important. How you are monitoring the scope. It's a costly thing. So before taking this flexible ureteroscope, you should be very good master in cystoscopy and ureteroscopy. And use of laser is also important. If you will see, it's a very easy procedure. We are going through the natural path. So there is no problem of any puncture. Just you are doing ureteroscopy with semi-rigid. Same thing we are going to do here.
Sir, I think so you should explain the laser settings also.
Yeah, right.
That's the most important technique.
Right. Here we will use the low power, high frequency. So we will make the dusting or little bit fragmentation. I have got this time IPG from Intercardia. This machine is of 60 watt, but we don't require that much power. Can you see this?
Yeah, it's a thurium laser, I suppose, because Initially, helium was the main.
Yeah, earlier we used to do this with helium. Still I am using helium. But this machine is better than that. It has got a very good high frequency, so dusting is better. Right, dusting is much better. So I am going inside through the semi-rigid ureteroscope. Here we can do cystoscopy with normal cystoscope also. Yeah, I am putting this ureteroscope directly. Otherwise we can do normal cystoscopy before putting this ureteroscope. Now feeding tube, usually I will not take much time for the removal of this stent. That's why I'm not putting. Otherwise, it's a normal routine to put some feeding tube, 8 number. This is a stent, right ureteric opening.
So putting a stent pre-operative is always a good thing.
Right. So this is the stone.
Yeah, we can see the stone nicely.
Yeah. So this time I can. It's an impacted stone. That's why it's so difficult. See this mucosa growing inside stone. So there should be very good relaxation, so that there will be and control of respiration, so that I can fire easily. Can you see it? It's a fine dusting is going on, and here I am using 150 micron fiber. It's a very thin fiber. Bending with this fiber will be easy if stone is in the lower calyx. But still we avoid to do that, because once the blood will come, the vision will go and we'll have to postpone the case. That is the most important thing. I am continuously watching the access sheath. Water is coming out or not. It's coming through access sheath. Even the stone fragments are coming through the access sheath. Yes, yes. Alpha blocker, 1 anticholinergic, 1 antibiotic for 1 week. No, not diuretics. Only 1 dose of injectable diuretic, Lasix, during surgery, means just after surgery.
Sir, very nice. Thank you very much.
Thank you, sir. I am performing second time in this OT.
Okay.
And just, I think before Corona, I have performed the same case, RIRS.
Okay, sir. Big applause from the audience.
So, thank you to
Thank you, sir.
Ajit sir for inviting me for this case.
Yes, Dr. Ajit has done very marvelous and very good job in a very
Yes,
successful
sir.
workshop.
Yeah.
And nicely demonstrated cases by the as well as lectures. We have very senior urologist with us.
Yes, sir.
He is
दिखा दीजिए सीआर व्यू दिखाइए फिर से फायर कीजिए एक बार फिर से.
Yeah, we can see the upper end. What about the lower end?
या अब नीचे दिखा दीजिए ब्लैडर में.
Because sometimes when you are pushing the guide, this digestion over the guide wire,
Yes,
it gets coiled in the bladder.
Yeah, this is also some. That's why I was asking to see show the bladder. थोड़ा और नीचे आके दिखा दीजिए. हाँ. Yes, the tip is in the prostatic urethra. I will put the catheter. It may go inside. Yes, it's now coiled inside bladder.
Yeah,
Can you
now
see?
it's coiled.
Yeah.
Yes, we can see that. It's coiled.
Yes. Thank you, sir,
Yeah, thank
for
you,
watching
Dr. Sudhir.
this.
Very
Yes.
nicely done procedure.
Thank you, sir.
Very nicely.